components of care in the management of asthma for our patients. They first are assessment and monitoring. The second is education. The third is controlling environmental factors and comorbid conditions. That last component is medications. As I mentioned here, these four major components begin with assessment and monitoring. First, we will assess the asthma severity to initiate therapy. This will include using a severity classification chart that helps identify the domains of impairment and risk, as well as what needs to be done in the initial treatment. Next, we will assess the asthma control to monitor and adjust the given therapy. This may involve the asthma control chart, assessing impairment and risk again, and how they manifest within the patient, and how they correlate with a given treatment plan. In this case, spirometry would be performed routinely every 1 to 2 years or more often as needed for patients with uncontrolled asthma. Finally, we will set up follow-up care as asthma conditions can change periodically, causing needed updates and changes to therapy. In general, the NAEPP guidelines suggest scheduling patients at 2 and 6-week intervals while they try to gain control of their asthma, and again every 1 to 6 months after asthma is sufficiently controlled. The next component is education. Patients need self-management education to reinforce what they have been taught. They must learn how to self-monitor the level of their asthma control and symptoms. If patients struggle in interpreting their symptoms, a peak flow meter may be particularly helpful. Patients may also benefit from a written asthma action plan, including the differences between their long-term control and quick relief medications. They also need to be made aware of the significance of how environmental factors can exacerbate their asthma. Patients must also be able to demonstrate correct self-administered medication delivery. After all these things, the patient and the practitioner need to develop a written asthma action care plan, agreeing on the treatment goals and addressing any patient concerns. This must be integrated into every patient interaction or visit, where practitioners reinforce these educational goals and continue monitoring effectiveness of educational strategies and methods. The next component involves controlling environmental factors and comorbid conditions by recommending measures to control exposures to allergens, pollutants, or irritants that make asthma worse. This will involve determining the exact exposures, the history of the symptoms from those exposures, and any sensitivities. Of course, we as practitioners advise our patients to avoid these triggers, especially tobacco smoke for pregnant women. It may also be helpful to consider allergen immunotherapy for those patients with persistent asthma and a clear correlation between their symptoms and a particular allergen. Finally, we want to treat any comorbid conditions that the patient may have. These include any of the following that you see here on the screen. The recognition and treatment of these conditions may improve asthma control. Also consider inactivated influenza vaccines for all patients over 6 months of age. The last component is medications, where a stepwise approach is utilized concerning medications and delivery options in order to meet the patient's need. Inhaled corticosteroids are the most effective long-term control therapy, but for each individual patient, consider the domains of relevant, patient's history of response to the medications, and the patient's willingness and ability to use the medication. The NAEPP's guidelines include a goal of stepwise approach. This stepwise approach and recommended treatments are meant to assist, not replace, the clinical decision-making necessary to determine the most appropriate treatment to meet the individual patient's needs and circumstances. General principles for all age groups include incorporating the four components of care, initiating therapy based on asthma severity, and adjusting therapies based on asthma control. This will include regularly assessing medications, patient education, environmental control measures, and management of comorbidities. For patients not on a long-term control therapy, treatment is decided on the severity. However, a persistent asthma may require daily long-term control medications. After therapy is initiated, the level of control will be monitored and adjusted accordingly. If there is difficulty in maintaining control, we can refer to an asthma specialist for consultation. Newborns to 4-year-old patients may require daily long-term control therapy due to their increased risk for severe exacerbations without obvious impairment. The NAEPP guidelines further describe what these patients will need. They will certainly need to be monitored closely with adjustments in their treatments made promptly when indicated. If no clear or positive outcomes have occurred within 4 to 6 weeks with satisfactory medication treatment and adherence, then the treatments may be stopped as alternative therapies are considered. However, if there is a clear benefit sustained for at least 3 months, consider stepping down the need for continued daily therapy. Children at this age range have high rates of spontaneous remission of symptoms. Patients between the ages of 5 and 11 can get involved in developing their own written asthma action plan that will promote physical activity while it monitors for disease progression and the loss of lung growth. This involves addressing any concerns the child or parent may have, as well as coordinating preferences and school scheduling of treatments. It's a good idea for this written plan to be with the child while at school or during afternoon activities. Children at this age need a few hours of exercise daily, but this may increase their risk of exercise-induced bronchospasm, or EIB. Daily therapy may be needed if the child has poor endurance or symptoms during normal play. Ultimately, treatments will not alter the underlying progression of the disease, but a step up in therapy may be necessary. Patients 12 years and older should be involved in developing their written asthma action plan that promotes physical activity, just like for children 5 to 11. We also want to assess the possible benefit of treatments that can establish reversibility with a short course of oral systemic corticosteroids. For these patients, we will also address coexisting medical conditions, such as the following. If there is a calcium and vitamin D for patients who take inhaled corticosteroids and have increased risk for osteoporosis, patients with an increased sensitivity to side effects of bronchodilators with increasing age, patients with increased drug interactions with theophylline, and keeping in mind that these medications for arthritis, hypertension, or glaucoma may exacerbate asthma as well. Keep in mind there are certain special cases to consider. For every patient, treatment should include prevention of exercise-induced bronchospasm with a long-term control therapy. Pre-treatment may include using a short-acting beta agonist, glucotriene receptor agonist, cromolyn, or needlecromol. However, frequent use of long-acting beta agonists for pre-treatment is discouraged as it may disguise poorly controlled persistent asthma. If the EIB is cold-induced, a scarf covering the mouth or mask may be used during warm-up. Even during pregnancy, asthma must be controlled during all prenatal visits, with albuterol as the preferred choice and inhaled corticosteroids as also the preferred choice for long-term control medication. Nearly one-third of women will experience a worsening of asthma during their pregnancy. However, another one-third may experience an improvement. Especially in these cases, it's safer to be treated with asthma than to have poorly controlled asthma. If patients are going to undergo surgery, lung function and medications have to be assessed. A short course of oral systemic corticosteroids may be necessary. If given 6 months prior to surgery, especially for patients on high doses of inhaled corticosteroids, they will be given 100 milligrams hydrocortisone every 8 hours via an IV during the surgical period and reduce the dose rapidly within the 24 hours after the surgery.